Today I will talk on one more controversial topic in total knee replacement, that is patellar resurfacing. The decision whether to resurface the patella and total knee arthroplasty has been debated for years. Factors often considered in the decision include obesity, the presence of chondromalacia, the degree of patellofemoral degeneration, and symptoms of preoperative anterior knee pain. We'll go through some of the studies published in the international journals. The relationship between the patellar resurfacing and the anterior knee pain represents its own perplexing problem. A 2001 randomized control trial comparing outcomes with and without resurfacing over a minimum 5-year follow-up found no between group differences in post-operative anterior knee pain. There was no difference. There was one study in JBGS 2001 on patellar resurfacing. There was no significant difference between the groups treated with and without resurfacing with regard to overall knee society score or the pain and function subscores. Obesity, the degree of patellar chondromalacia, and the presence of preoperative anterior knee pain did not predict post-operative clinical scores or a presence of post-operative anterior knee pain. Post-operative anterior knee pain was probably related either to component design or details of the surgical technique such as rotation of the patellar component. There was a concise follow-up of a randomized trial published in JBJS 2009 on patellar resurfacing compared with the non-resurfacing. 57 patients, 78 knees were followed for a minimum of 10 years. No significant differences were identified between the two groups in terms of the range of motion, knee society scale, satisfaction, global knee pain, or anterior knee pain. The 7 revisions of the non-resurfaced patella for the treatment of anterior knee pain were all performed within the initial 5 to 7 years after the primary total knee arthroplasty. In contrast, the 2 revisions related to patellofemoral problem in a resurfacing group were performed after 5 to 7 years follow-up of interval. Another randomized control trial involving earlier total knee arthroplasty designs found the prevalence of anterior knee pain was more than 25% in the non-resurfaced group compared to 5% in the resurfaced group. These authors recommended routinely resurfacing the patella. Most probably the pain was related to the earlier knee designs. This study was published in 2003. Some surgeons recommend patellar resurfacing for the patellofemoral arthritis or if there is a cartilage damage of the patella. There is one classification, that is Outbridge classification for a grading of joint cartilage breakdown. Grade 0 means it is normal. Grade 1, cartilage with a shortening and swelling. Grade 2, a partial thickness defect with the fissures on the surface that don't reach subchondral bone or exceed more than 1.5 cm in diameter. Grade 3, fissuring to the level of subchondral bone in an area with a diameter of more than 1.5 cm. Grade 4, exposed subchondral bone. There was one study in CORR May 2010 on the Outbridge classification. According to them, the Outbridge classification predicts the need for patellar resurfacing total knee arthroplasty. A randomized study of 500 total knee arthroplasties found a 21.5 times greater risk of the need for the subsequent patellar resurfacing in patients with the Outbridge grade 4 patellofemoral degeneration compared to those with the lesser grades. They form two groups, Group A, Group B. Outbridge grade 1, 2, 3 formed Group A, whereas patients with the Group 4 formed the Group B. Patients in Group A required fewer revisions for the patellofemoral pain. In Group A, only one patient required a secondary patellar replacement, whereas in Group B, 10 patients needed a patellar resurfacing, that is 11.6% rate. In Group B, that is with a grade 4 patellar degeneration, the risk for need of a patellar resurfacing was 21.5 times greater than in Group A. On the basis of these findings, they recommended patellar replacement in Outbridge grade 4 patella, not in grades 1, 2 and 3. Patellar resurfacing in total knee arthroplasty. Does design matter? No significant differences were found between the resurfacing and non-resurfacing groups with regard to the incidence of anterior knee pain. Analysis of homogeneous data comparing patella-friendly with non-patella-friendly total knee arthroplasty design demonstrated no differences in the incidence of reoperation. No evidence was found to suggest that either patellar resurfacing or the prosthetic design affects the clinical outcome of total knee arthroplasty. There was one study on the cost in patellar or non-patellar replacement. A randomized control trial of more than 1,700 patients found that total healthcare costs of 5 years after total knee arthroplasty were not significantly different whether or not patella was resurfaced. A more recent meta-analysis of more than 3,400 total knee arthroplasties found that patients who underwent the patellar resurfacing had rates of anterior knee pain and overall satisfaction that were equivalent to those whose patella were not resurfaced. However, the resurfaced group underwent a significant fewer additional procedures. Australian Orthopedic Association Registry recommends a patellar resurfacing. They suggest an early beneficial outcome for patellar resurfacing at a primary arthroplasty based on revision rates up to 5 years. But this is a very short follow-up in a replacement. In summary, despite results from various randomized clinical trials, anterior knee pain and its relationship to patellar resurfacing continues to be a perplexing clinical problem, and so you can do a patellar replacement if there is an extensive cartilage damage. Otherwise, in Indian setup, you can just trim the osteophytes and denervate the margins and leave the with the original patella.